So I'll get started while Randy's queuing us up here, and I'll try to speed along. I appreciate you tolerating our being behind a bit. I'm Dr. Cotter, Clement Cotter from Birmingham, plastic surgeon. Why am I talking about breast cancer? Because I work with about 6 or 7 general surgeons, and I see it done all kinds of different ways. Maybe for the talk and for time, some of the things that, if you can remember just some of the words. I know most of you are not, how many general surgeons do we have? Couple. So you'll recognize these words. The remainder, these are the new concepts. Giving neoadjuvant chemotherapy before surgery. Skin sparing mastectomies is what we do very commonly. There's a new phase of nipple sparing mastectomies that we used to never do. The phrase oncoplastic breast conservation, plastic surgery with lumpectomy basically. Some of the newer intraoperative options, using radiologic techniques in surgery to help find the tumors, treating with radiotherapy during surgery, and some of you heard Mammocyte. Do either general surgeons use Mammocyte? Any of the radiologists or radiation oncologists? Sentinel Node biopsy has become a very big part of breast cancer surgery. When to do it with ductal carcinoma in situ. Is it done as a separate procedure? Is it done with neoadjuvant therapy and how to use it there? Do you look at the internal mammary nodes now rather than just the axillary nodes? And what do you do if you find a positive lymph node? Is it a micrometastasis? Is it a macrometastasis? And what does that mean? Do you have to go back and get all the lymph nodes or not? The reconstruction, as plastic surgeons, yes, we too have now gone to evidence-based reconstruction. We've got better tissue expanders, better implants. We use all kinds of different techniques. Most of you know what the tram flap is. It's pretty much standby. Latissimus dorsi still gets us out of a lot of trouble. Did one this past week for a radiation wound on the chest. The microvascular flaps have taken a lot of place. The free tram, or some people refer to it as the double barrel tram, where you actually take the tissue loose and sew it into 2 different sets of blood vessels. You can remember these last couple, the DIEP you'll hear and see, deep inferior epigastric perforator flap, which is kind of a variant of the tram flap, and its cousin, the superficial inferior epigastric artery flap, both from the lower abdomen. The gluteal flap is still used sometimes. This is something that's very important, and as breast cancer surgery evolves and breast cancer care, the multidisciplinary approach is very important. The places that have dedicated clinics have lower risks of death for their patients. You see more breast conservation, lower complications, shorter lengths of stay, and especially more adjuvant therapies. We're seeing much more neoadjuvant therapy now before surgery. And there's just kind of a little caveat, there's a little side thing I learned this past week. In the northeast part of the country, maybe this is apropos for us being in the south for the most part, northeast, about 20% of the breast cancer surgeries are conservative, or lumpectomy and radiation. In the southeast, 80% are mastectomies. It's exactly the opposite. And so there's a real geographic disparity. Nobody's quite sure why. It may have to do with access or, what therapies may have insurance implications, a lot of different things. Other issues, I think if you've been paying attention to the news lately, Angelina Jolie had a prophylactic mastectomy. Christina Applegate There's a variety of different ways to do it. Total mastectomy, subcutaneous, nipple sparing. It's not completely 100% effective, but pretty effective. Has a lot to do with the items up there, family history. The BRCA gene is a big issue right now. I think that's what Angelina Jolie had. We're still having problems with the difficult cancers. Most of these are involved with the neoadjuvant therapy now, and a lot of research being done into the chemotherapy, combinations of chemotherapy for these. A word to remember you'll hear sometimes is triple negative. So estrogen receptor, progesterone receptor, and HER2 negatives, they are very difficult to treat. A lot of the new chemotherapy agents are being used in combination. All this started about 30 years ago. It's not finished evolving. One of the things that you will see are women seeking this multidisciplinary approach. They want the newer techniques. They come in more prepared. They've been on the internet. They know a lot about what they want. When I see them for reconstruction, they pretty much already have it figured out. Unfortunately, they're really scared, and that's a very difficult consultation. And these are a couple of references, and maybe we'll leave it there for the sake of time.